So good morning, everyone. Welcome to symposium number 128, is asymptomatic infection true asymptomatic malaria. So we've got a great set of speakers this morning, and Rolly and I purposely chose this topic because we thought it might actually be a touch contentious or controversial, and that's good. We want to stimulate a debate. We, including myself, have talked about asymptomatic malaria for many, many, many years, and I can recall doing studies on asymptomatic malaria in the Peruvian Amazon many years ago. And the first thing I found out is I actually didn't know what that was, and it was pretty difficult to define and describe a start and a stop. And so mentally, over the years, have really thought of this as a chronic infection, which it truly is. So the question is this chronic infection actually harmful to individual people as opposed to a reservoir for transmission? Because I think it does have if you conclude one way or the other, it makes it a little different in how we think about going forward. So let me introduce my co-chair, Rolly Gosling, and let him make a few comments and we'll get started.
Thank you, Alan. We talk about asymptomatic infection, and we especially address that in elimination settings. But I think today, Alan and I really want to get the discussion going about asymptomatic carriage in all transmission areas, and really kind of reflecting a little bit on the experience of HIV, how initially in the beginning of the epidemic, the HIV epidemic, we really didn't address HIV infection until it became symptomatic. And when we think of treatment for prevention of HIV, now we're treating very early on. And there was some discussion yesterday in another symposium really around that issue of really changing the paradigm of thought about infection, malaria parasite infection. So that's kind of like an opening for you. We hope for some lively discussion. We hope some people will have a distaste for the presentations and stand up and argue against us. So I think without further ado, we'll invite Wendy up. Wendy O'Meara, can you give yourself a little introduction and then, is asymptomatic malaria infection really asymptomatic?
So I don't know what it means that Rolly doesn't know me well enough to introduce me, but good morning. My role in this symposium is to discuss a little bit from an epidemiologic standpoint whether asymptomatic malaria infection is really asymptomatic. So I think it would be first useful to define asymptomatic infection, and I haven't really discussed this definition with the session chairs, but since I'm the first presentation, I get to define asymptomatic malaria. So what do we mean by asymptomatic malaria? So for the purposes of my talk, I'd like to define asymptomatic malaria as an infection that would not cause disease on its own. So in a particular host, it's an infection that would not today or in the future cause disease on its own. And of course, this is quite specific to the host because it depends on things like age, previous exposure, and immunity. But for the purposes of our talk, let's use that definition. So the question that we're trying to answer is whether that parasitemia, that asymptomatic parasitemia, could be a necessary component cause that constitutes a sufficient condition for another illness. Or a secondary, perhaps easier to prove and discuss question is whether infection with malaria, a concurrent infection with malaria, would lead to more severe disease from another cause than without that concurrent malaria infection. And so mechanisms that might underlie these observations will be discussed in other talks in this symposium. So from sort of a classic Rothman epidemiological perspective, looking at causal relationships leading to disease, these are sufficient causes for fever. Each circle represents a sufficient cause for fever. So we know that parasites on their own can be a sufficient cause for fever. We know that influenza on its own can be a sufficient cause for fever. And an individual could be infected with malaria and with influenza and suffer from a fever. And so the question is whether these parasites are a necessary component of this this sufficient cause for fever. So if we remove the parasites, would that person still suffer from fever? And likewise, if the patient had only parasites and not the influenza, would they still have fever? So if malaria is a necessary but not sufficient causal component of a fever case, then what would we expect from some observational data? So imagine that we suddenly remove parasites from a population. What might we expect to see? So there's a possibility that we might see no change in all-cause morbidity. So I'm going to talk about all-cause morbidity because if you remove all the parasites from a population, you remove malaria-specific morbidity. So we're interested in what would be the results on all-cause morbidity. So if you remove parasites from this population, you might see no change in all-cause morbidity, and this would basically mean that your parasites are completely coincidental in all of your morbidity events, and they're not actually causing any disease. Or you could possibly, at the higher end, see a morbidity reduction that's equivalent to the total parasite-positive fever cases. And this would mean that all of your parasite infections are causing disease, or your malaria attributable fraction is approximately 1. And malaria attributable fraction is the fraction of parasite-positive morbidity events that are actually caused by the parasites. So the parasites are responsible for the fever. So most often we would expect to see that overall morbidity, all-cause morbidity, would be reduced by something less than the total positive fever cases, indicating that the malaria attributable fraction is less than 1. And of course, the fact that malaria attributable fraction can be less than 1 is why we're in this symposium, because if malaria attributable fraction were always 1, then we wouldn't be here having this academic discourse about asymptomatic infection. And we might also, just to cover all our bases, we could possibly see morbidity reduced by more than the total positive fever cases, but this would be difficult to explain from an epidemiologic perspective. So that's outside of my mandate. Okay, so most often we expect to see morbidity reduced by something less than the total parasite-positive fever cases. But the question is, how much of a reduction would indicate a contribution of asymptomatic infection to overall morbidity? And so we could argue that a reduction that exceeds the fraction that's attributable to malaria would indicate some additional benefit. So the reduction that exceeds the total parasite-positive cases times the malaria attributable fraction. All right, so if transmission is very high and exposure is very high and malaria attributable fraction is low, then you won't actually see a large benefit of malaria control on total morbidity unless your asymptomatic infections are causal, okay? But this argument obviously hinges on being able to measure malaria attributable fraction very accurately, and typically we measure malaria attributable fraction by comparing asymptomatic individuals with parasites to symptomatic individuals with parasites, and specifically comparing the density. So coming up with a model that estimates the probability that your fever is caused by parasites based on the density of your infection. And of course, density of infection varies both with transmission and with immunity. So malaria attributable fraction will certainly change as transmission changes. So it's a little bit of a moving target. But let's review a little bit of the experimental evidence that's available and see what we can learn about this issue. So this experimental evidence is from the Gambia. This was a chemoprophylaxis study, a randomized placebo-controlled trial in the mid-1980s, where kids who were aged 3 months up to 5 years were protected with bi-monthly dapsone-pyrimethamine. And after 1 year of protection, the incidence of fever cases associated with parasitemia was much lower in the treated group, a difference of about 8 per 1,000. And about half of this difference was due to very high parasitemia infections. But interestingly, the difference between the placebo and the treated group around all fevers was 0. So keep in mind that these kids were, this was 1 year of protection, but these kids were aged between 3 months and 5 years. So quite a good proportion of them had already had significant exposure to malaria. So what we might assume is that the malaria attributable fraction was very close to 0 in this group at this time point. But then after a further 3 or 4 years of chemoprophylaxis, we see that there's still a much lower incidence of fevers associated with parasites in the treated group. And now we see also a reduction in all-cause morbidity in the treated group. And it's somewhat less than, as we predicted, it's a little bit less than the reduction in fevers with parasites, indicating that the malaria attributable fraction is a little bit higher now. But we still are not sure if this represents an additional and excess reduction beyond those attributable to malaria. So a companion publication to this study, they looked at other causes of morbidity in these two groups, and they showed some evidence for slightly higher rates of gastroenteritis in the placebo group, but equivalent rates of illness associated with cough or breathing difficulty. And they also showed that more children in the placebo group seroconverted for rotavirus and RSV. The difference was very small, but and the latter was only evident in older children. But this is some evidence that suggests where we might see this synergy between protecting from malaria and other causes of morbidity. There's another chemoprophylaxis study that I want to highlight from Tanzania, and this one was done in infants. So infants were enrolled at birth, and they were protected for 1 year. So we would expect the malaria attributable fraction in this group to be near 1. So what they showed was that malaria-specific outpatient visits, so morbid events associated with parasitemia, were reduced by about 0.4 per person year at risk compared to placebo. But the all-cause outpatient visits were reduced by almost twice that, so the reduction was greater in all-cause morbidity. So you could potentially think of reasons to explain this observation. One would be that they're reducing some kind of submicroscopic parasitemia that's protecting from outpatient visits, or it's possible that the drug they were using, which was also dapsone pyrimethamine, was effective against other causes of fever, or potentially that the relationship between malaria infection and other causes of morbidity doesn't have to be temporally linked. They can be separated in time. Okay, and then we have one more piece of experimental evidence from an ITN study. Most ITN trials reported all-cause mortality, but this one actually reported all-cause morbidity. So this is from Kenya in the mid-90s. And I've just presented here data from the ITN group because there were no changes in any of these parameters in the control group. So all admissions declined by about 7 per 1,000 in the pre- and post-intervention period. Slide positive admissions declined by almost twice that. But what's interesting is that all that difference between the slide positive admissions and the all admissions is recovered here in the slide negative admissions, which increased. So basically there was no additional benefit in terms of reducing morbidity beyond the reduction in slide positive admissions. So in other words, these kids who were showing up to the hospital and being admitted with parasitemia, where the parasitemia wasn't the cause of their fever, they're still being admitted, but they're just being admitted without parasites. Okay, so a little bit of observational evidence. This is data from Khalifi from 1990 to 2007, where we saw that all admissions here in blue and slide positive admissions in red, they pretty much tracked over the study period until sort of the early 2000s when we saw a decline in both, but we noticed that the rate of decline in all admissions and slide positive admissions might not be parallel. So to try to understand this, we looked at all-cause admissions before this decline and all-cause admissions after the decline, and we saw a reduction of about 10 per 1,000. This is average annual figures. And then we looked at admissions with parasites, which were about 20 per year on average per 1,000 before the decline, and it declined by about 13. So to try to understand whether there was an excess reduction in morbidity associated with declining transmission beyond those attributable to malaria, we calculated the malaria attributable fraction in the pre-decline period, and it was about 60%. So 60% of parasite-positive admissions were actually due to their parasitemia. And if you multiply this change by this 60% malaria attributable fraction, the expected reduction in all-cause admissions was about 7.8 per 1,000, but the actual difference was 10.3, and so we have this bonus reduction of about 2.5 or about 20%. And there's some data from the same hospital in the same time period that shed some light on mechanistically why we might be seeing this. What Anthony Scott et al. Reported was that the odds of having invasive bacterial disease, if you were heterozygous with the sickle cell trait, so if you're had sickle trait, the odds of having invasive bacterial disease was much lower. But this effect, this protective effect of carrying the sickle cell trait was only observed when malaria incidence was relatively high. So as malaria incidence declined, this protective effect decreased until it eventually went away. And so what they conclude is that HBAS is associated with protection from invasive bacterial disease, and this is mediated through protection from malaria. So in other words, in our framework, we would say that malaria is a necessary component cause for some sufficient conditions of invasive bacterial disease. So a potential mechanism linked to the reduction in morbidity that we saw. So I'm going to step a little bit outside of my mandate for a second and talk about mortality. There were a few studies that report all-cause mortality, including some ITN studies that are interesting. The picture that we see around all-cause mortality is much more consistent, actually, and maybe a little bit easier to interpret than the morbidity data. So this is, again, from the chemoprophylaxis study in the Gambia, and they showed that all-cause mortality was much lower in the treated group at the end of 1 year of protection, a difference of about 20 per 1,000. Malaria-specific mortality, the difference was half that. And again, this was borne out again after 3 to 4 years of protection, where the reduction or the difference in malaria-specific mortality was only a third that of all-cause mortality. So mortality declining much more than malaria-specific mortality. And malaria mortality in these studies was measured by verbal autopsy. We normally think of verbal autopsy as being very sensitive, but not very specific. So potentially overestimating malaria mortality in these figures. So data from ITN study, this was a cluster randomized study in the Gambia. And children had either an insecticide-treated net or an untreated net. And again, all-cause mortality was significantly lower in the intervention group. But malaria mortality was not significantly lower in the intervention group. And the difference, again, is about twofold, again, by verbal autopsy. And then one more ITN study from Ghana around the same time period. This is comparing children with ITNs and children with no nets. Significant reduction in all-cause mortality, not a significant reduction in malaria mortality, and again, the difference between the two is about twofold. So I guess the question is, can we conclude from these data that malaria infection is some necessary component cause of some multifactorial mortality events? And are those mortality events, do they not look like malaria on verbal autopsy? Okay, so just to summarize, when malaria attributable fraction is very low, we don't see a big reduction in morbidity when we reduce exposure. But when malaria attributable fraction is a little bit higher, around 60% in Khalifi or possibly near 1 in infants, we do see excess reduction in morbidity from preventing exposure. And the picture is a little bit more consistent around mortality. We see that mortality is consistently reduced by more than the total positive or the total malaria attributable mortality events. Okay, so what's the relevance of this? I think it's useful and interesting to try to estimate the expected additional effects of elimination on disease burden and especially on mortality. And then, of course, a more immediate question, I think, that was already alluded to by our organizers is that we would like to know whether we should be targeting this asymptomatic carriage in some populations. So I don't have an acknowledgement slide, just to say that all errors and omissions are my own and should not reflect poorly on any of the other panel members.
Okay, are there any questions? Is that a question, or are you heading out? Yeah, please step up to the Thank you.
Good morning, and thank you for an excellent presentation. I've always wondered in the relevance of asymptomatic malaria for things like HIV. And I was wondering what your thoughts would be of malaria you can detect but is present at some level in the context of a chronic disease like that.
Yeah. I'm not sure if I have anything really intelligent to say about that, except to say that I've attended several sessions where it seems like the harder you look and the more sensitive your PCR is, the more malaria you find. And I think defining a spectrum of detection within the context of understanding asymptomatic malaria will be really important. And I'm sure that HIV-infected people will be a very interesting subgroup to look at, because the relationship between density and morbidity will be different than in immune-competent hosts.
Yes, I guess there is an additional question: is what do you call an asymptomatic infection? That means, what do you call an infection? I guess most of the studies you talked about were relatively old studies, and probably that 6 diagnosis. We know that if you use more sensitive techniques as qPCR, you will find much higher number of infections, with probably very low densities.
Okay.
And maybe the impact of this low infection is the same or not the same.
Yeah. I think that's a good point. I think it speaks to this question of how do you define asymptomatic malaria, and I defined it in a very theoretical way, but obviously in a practical sense you have to detect the parasites and then define whether it's symptomatic or asymptomatic, and the more sensitive technique you use, the more infections you'll find. And I think these studies, they didn't have rapid diagnostic tests, but they did very good microscopy, and so but my sense is that this relationship between parasite density and symptomatic disease will scale. I mean, I think it'll be proportional even if you detect additional infections. I'm not sure if that answers your question. Maybe I can't answer your question. I don't know.
Thank you very much, Wendy.